And now I'm going to go ahead and introduce our fantastic speaker. We have May Kwong. She joined CCHP in March of 2010 as a policy associate and was named executive director in January of 2018. She leads the organization's work on public policy issues as they impact telehealth on the state and federal level. May is also the project director for the National Telehealth Policy Resource Center. So I'm going to go ahead and stop sharing. And May, take it away.
Thank you, Antonia. Thank you for having me here today. As I pull up my slides, I was listening to Antonia talk about asking for your suggestions for February to June of 2027, certain topics. May I suggest that you might want to consider doing a update on what is going on with the Medicare flexibilities, and you'll understand why I'm suggesting that for like out into 2027 once I like get a little bit more into like my presentation. Um, let's see. As Antonia said, my name is May Kwong. I am the executive director at the Center for Connected Health Policy. Before we get started, just a couple of quick disclaimers that I need to make. First off, I am not providing you with legal advice. I am strictly providing you with informational and educational information today. If you are interested in a formal legal opinion, CCHP always recommends that you consult with legal counsel. And also know that if I happen to mention a company or show a picture of a product, neither I nor CCHP has any type of relationship or financial arrangement or interest with such a company. Um, just very quickly, Antonia, I just want to do a quick check-in. It seems like my video is lagging. I'm just wondering if that's on my end or if that's on, are you guys seeing that as well too?
We are seeing that as well, so it might be helpful if you turn off your camera.
I was just going to suggest that just to make sure you don't really need to see me. So let me just stop video. And a little bit of background about CCHP. We were established as a program underneath the Public Health Institute back in 2009, actually as a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant. At that time, it was a grant from HRSA. CCHP applied for that and we got it, and we've been serving in that capacity ever since. So almost 15 years as the National Telehealth Policy Resource Center. We also work with a variety of other funders and partners on the state and federal level on sort of more specific focus projects. We are also the administrator of the National Consortium of Telehealth Resource Centers. I'll explain that in a second. And we convene a group in California called the California Telehealth Policy Coalition. Now, the National Consortium of Telehealth Resource Centers are made up of the 14 telehealth resource centers who are funded underneath the same funding stream that CCHP is. There are two national centers. CCHP is the one on policy, and there's one on technology. And then there are 12 regional resource centers. Antonia with UMTRC is the one that covers the upper Midwest. And then there are 11 other regional resource centers that cover specific states. A few years ago, we all came to the conclusion that we were doing some work that was overlapping or duplicative of each other. So, in order to make our very limited resources go as far as they could, we agreed to do a joint collaboration and formed it underneath this umbrella called the Telehealth National Consortium of Telehealth Resource Centers. What that means is we pile a bit of our resources into a common pot in order to do these joint and collaborative projects to make sure that again that we're not duplicating each other or overlapping on each other, just to again work more efficiently with our resources here. I highly recommend that you reach out to the telehealth resource centers that cover your region. Obviously, you guys have been engaging with UMTRC. That's great. I encourage you to suggest other people do that as well if they have any type of telehealth questions. The telehealth resource centers have some of the most experienced telehealth folks in the nation. There's like a long history there. There's a lot of experience. So highly recommend that you reach out to them with any telehealth question. And if they can't answer it, they've got 13 other resource centers that they can rely on. And usually somebody has an answer. And if no one does, somebody usually goes out and tries to find one for you. So I cannot recommend enough that you really stay in touch with your telehealth resource center. There. Okay. So the agenda for today, I was asked to talk about the Medicare telehealth waivers and to really focus in on four areas here: eligible practitioners, the audio only portion of things, the behavioral health prior in-person requirement, and how the waivers are affecting FQHCs and RHCs. So I'll do like kind of an overview first and then dive a little bit deeper into each of these areas. So, what is the current federal telehealth policy? So, I'm assuming most of you probably are aware of this, that the Medicare waivers were extended until the end of 2027. So, they will expire at 11:59 p.m., December 31st, 2027, currently. That's the current policy right now. This was in HR 7148, which was passed late last year. That was the bill that essentially ended the federal government shutdown, but it also had the telehealth waivers extension in that bill as well. And basically, what it did was just carry forward the extensions that we have all been used to and have been familiar with over the last couple of years. So that's waiving the location requirements, allowing the greater, more expanded list of providers who are eligible to provide services via telehealth and get reimbursed by Medicare, allowing FQHCs and RHCs to remain as eligible providers, delaying the prior in-person mental health visit, delaying the prior mental health visit for FQHCs and RHCs, allowing audio only to be used, and extending the use of telehealth for face-to-face encounters, recertification of eligibility for hospice care. So these are the general things that, we've all been accustomed to living under the last couple of years, really since the end of the pandemic and during the pandemic as well. There was just that brief blip when there was the government shutdown for about 6 to 8 weeks. I can't remember the exact number, but for about 2 months last year, in the fall of last year. But the waivers were applied retroactively. So, even though that period of time was a little bit confusing, nobody should have not been paid because they were applying those policies backward retroactively to like when they expired. We have them around for, essentially at this point, like another 18 months until the end of 2027. And then what happens from there, that's still a question mark. A couple of things, though, that people may not have recognized. A lot of the focus was on in HR 7148 on, oh, the Medicare waivers, but there were a couple of other things in there. Some of them not policies that we had necessarily over the last couple of years, but that were put in this bill that impact telehealth. And these are things that you will see crop up probably over the next couple of 6 to 12 months as they're being dealt with, like the agencies that oversee this particular type of policy. So the first one is the creation of new billing modifiers, and that is when telehealth services are going to be delivered through a third-party platform where basically the clinician has a contract or some sort of agreement, some payment agreement with that platform, and when telehealth is billed incident to another professional service. So this gets to, I think, sort of like identifying more where telehealth is used, especially if a third party is involved in some way, in this case, like a telehealth platform, and like how many of these healthcare professionals are using those platforms and have that type of arrangement there. So it's not necessarily, these modifiers necessarily won't apply to somebody, like a large institution who maybe has created their own sort of like telehealth platform to do things. It's only when you are using somebody else and you have some type of payment arrangement in there. That we may actually see crop up in this year's physician fee schedule. They need to have that done by 2027. So my guess is like the vehicle that CMS will use to like create those modifiers is probably the physician fee schedule when they use that to decide their policies, new policies for 2027. So keep an eye on that. That usually comes out, at least the proposals, in July of the year before. So come out in July of this year for the 2027. So that I think will probably pop up in there. And then through 2027, hospitals will be allowed to furnish and bill for Medicare for cardiopulmonary rehabilitation services to hospital outpatients in their home via live video. This was, I think there was a small gap specifically for hospital outpatients because I think this was allowed for physicians practices to do this, physician offices. But there was this like kind of bit of a policy gap there for hospital outpatients where they didn't allow that or didn't extend that. And so that was put in here as well too. And then within this bill's passage, HHS must issue guidance on best practices for delivering telehealth services to patients with limited English proficiency. This is something new. It's not something that we had seen in previous years. It's within a year. So again, it's something that HHS must come up with within the next couple of months to meet like the dictate of like what Congress put in here. And then there is another thing that we hadn't seen beforehand that's requiring CMS to educate Medicare clinicians by January 2028 on screening for medication-induced movement disorders in at-risk patients, including best practices for telehealth screening and how such services should be reflected in billing. And that's pretty much what it sounds like is if there is like a movement disorder that's induced by some sort of medication in certain patients, they need to have these best practice guidelines. And one of those, what should be included in those guidelines is how telehealth is used in the screening as well too. Um, Other things that it did, this was interesting. So acute hospital care at home initiative, they extended that out to September 30th, 2030. So a little bit different than some of the other dates we've seen, like on the previous slides, where it's at, oh, it ends in 2027. This got actually like a couple more years. It's extended out to September 30th, 2030. And also not until like the end of the year. It's like stops in September too. But this is proven to be a fairly popular program. From what I understand, I've sat in a couple of congressional hearings, or listened in. I didn't really sit in there, but listened into a couple of congressional hearings, and there was a lot of interest in supporting this program. So they've had an extension to 2030. I think the reason for the longer time is they are trying to capture some more data regarding the efficacy of this program. So that's why it's probably like a longer time than what we're seeing for some of the other types of proposals on the previous slides. And then a couple of other things require Medicare Advantage plans to include certain information on provider directories, including like the telehealth capabilities of those providers. And then $1 million was allocated to purchase, excuse me, an implementation of telehealth services and other efforts to improve healthcare coordination for rural vets and between rural providers and the VA. So those were a couple other sort of more hyper-specific things related to telehealth that were in that bill. But back to our Medicare sort of waivers and the telehealth policies. This is just like sort of your quick reference on sort of what is allowed there that is going to be waived until the end of 2027 and what you can continue to do. Now, again, I was asked to focus in on a couple of the more specific policies here. And before I do that, I wanted to do this. I like to use this slide because to make it easier for you to understand telehealth policy in general, I always say a lot of the policy around telehealth, especially when you're talking about reimbursement policy, is built on 4 factors that they look at, that they will have like some payer will have a policy related to one or more of these factors. And these factors are where, who, how, and what. So where is like, where's the patient located at the time of telehealth service? Who is the provider type? What type of provider are they? Are they a, physician, a nurse, a psychiatrist, etc. And how is the service being delivered? So what modality is being used? Is it live video? Is it async? Is it remote patient monitoring? Is it audio only? And then the what? What type of service is being provided? Is it like, do they have broad categories such as like, oh, it will be for, dermatology, or, oh, it's mental behavioral health, or do they do it by like specific CPT codes, which is how Medicare does it. They say they have as what are their eligible services, a very specific list of services, and it goes by like the actual CPT or HCPC code. So let's tackle sort of like the first area we want to talk about, which is eligible provider, and that is our who. So what is the provider type that's eligible to continue to provide services via telehealth and that Medicare will reimburse? And it is essentially all eligible Medicare providers. So it is the same policy that was um, invoked in COVID, and it's been extended out until this point. And it is like, well, if they're a provider that is like Medicare eligible and they're able to provide a service on that list that we say that we reimburse if you use telehealth, then they can get reimbursed by Medicare. And this includes like your PTs, your OTs, your speech language pathologists, and also it includes FQHCs and RHCs. Now, permanent policy, if this waiver was not in place, that list shrinks down considerably. So, permanent policy has a very limited list of eligible providers, and it does not include all those folks that I just rattled off. It does not include your OTs, your speech language pathologists, your audiologists, your PTs, and to an extent, it does not include FQHCs and RHCs. They would not be eligible telehealth providers. However, I'm going to put a little asterisk by there and I'll explain why FQHCs and RHCs are a little bit unique. But keep in mind, without this waiver in place, these other types of providers would not be allowed to provide services via telehealth and get reimbursed by Medicare. It does not mean they can't use telehealth at all. They definitely can't. It just means that Medicare would not reimburse for them if we weren't in this waiver sort of environment right now. Um, and the other thing is like who is on that eligible list again is very limited. It is probably about like I think 10 different professionals. So it's like physicians, it is dietitians, it is mental health counselors and marriage family therapists, and a couple other folks. So it's a very limited list of who would be eligible if we were underneath permanent Medicare telehealth policies. Now we're going to move on to the where. So the where is the location of the patient. And again, with the waivers, what happened is that they remove these requirements of like where the patient had to be during the telehealth interaction in order for that service to be reimbursed. And they had two requirements. There had to be like a geographic requirement that is met, and then there has to be like a site requirement, like a type of location that the patient is in. And underneath permanent policy, the patient would have to be in a rural area. That's the geographic requirement. And that they had a very specific definition of what geographic meant. So if you were thinking like, oh, I would qualify because I'm like in a rural area, there's like nothing around me. It may not because of the hyper-specific definition that Medicare has. And it's based on census tracts and it's really complicated, but what CMS has done is had created like a telehealth eligibility analyzer where you can type in your address and it'll tell you if you qualify. However, that's waived until 2027 again. But if we were in permanent policy, that requirement would need to be met. Then there is a site requirement, which means the patient needs to be located in a particular type of building during the telehealth interaction. And again, that's very limited. It's usually like some sort of healthcare facility. So it's like a hospital, a doctor's office, or a clinic there. Now, there are exceptions. This is where permanent policy gets like a little bit trickier or a little bit messier in that they carved out these exceptions in permanent policy in that geographic requirement, we'll take that first, would not apply to certain things, and that is treatment for certain conditions there. So the geographic requirement does not apply underneath permanent policy if you are treating stroke or if you are treating end-stage renal disease. So that goes away there for like those particular types of conditions you're treating. Additionally, the site requirement would not apply. Like you have to be in a certain type of location, which is essentially a health facility, in order for telehealth to be covered by Medicare, would not apply for, again, for certain types of conditions. And that is, again, for end-stage renal disease. So you can do some end-stage renal disease services in the home and not meet those geographic requirements. So there's that exception carved out for them underneath the permanent policy. There's also an exception for mental health. And that's there's two exceptions for mental health, or two ways to approach mental health. So for mental health, underneath the permanent policy, you would not have to meet the geographic or site requirement, which means you can do it at home and you can do it in an urban area. If you were treating a patient for substance use disorder and they were also being treated for a mental health disorder. So, or a mental health condition. So that is one way for mental health to not have to meet those permanent policies of geographic and site requirements. And also the other one that does not need to meet the geographic requirement of site and um, geography underneath permanent policy. I said end-stage renal disease, but also for treatment of substance use disorder. Um, but going back to mental health, that is one way in Medicare underneath permanent policy where mental health can avoid having to meet the geographic and site requirements. If it is like a dish, if the patient is also being treated for substance use disorder and they have another condition for mental health that needs to be treated. That's one way. The other way is that prior in-person visit. So this is where the prior in-person visit comes in. This is where it is in permanent policy. And, it says in statute that you don't have to meet the geographic requirement and you don't have to, be in a clinical setting in order to reach services to treat a mental health condition. And you don't have to have that substance use disorder being treated as well, too. If you just have a mental health condition that needs to be treated and you don't want to have to meet the geographic or the site requirement, you can do that underneath permanent policy, but you've got to have a prior in-person visit. And that prior in-person visit needs to take place 6 months before the telehealth visit starts. That is where that prior in-person visit comes in. Now, again, that prior in-person visit, you don't have to worry about that now. That has been waived until the end of 2020, 2027, just as well as like the other telehealth conditions. However, and this it did kick in for that brief period when we have that shutdown, but again, that it didn't apply because there was like they did the extension retroactively. But should these waivers, or if this specific waiver of waiving the in-person requirement is not extended beyond 2027, it would kick in on January 1st of 2028. So that is where your prior in-person visit comes in. You don't have to worry about it now. However, if it's not extended, you do have to worry about it in 2028. I will say this prior in-person visit, I don't understand where it came from. It was like put into law at the end of 2020. I remember this because I was like watching that bill. It was put in law by a budget bill, an appropriations bill at the end of 2020, and nobody really knows where it came from. Like we don't know whose idea it was to stick this in there. But over the years, it's become, I think, a policy that some policymakers have like questioned the need for. So there is always the possibility that at some point it gets removed from statute, but right now it is in federal law. So without the waiver here, this would be something that you would need to meet if you were trying to like get services to a patient who didn't meet the geographic requirements or like the site requirements. Audio only. This is the modality of delivering services. And basically right now, CMS has said that, if you can provide the services via audio only, then you can go ahead and do that. Just remember to put the modifier on there. That's a little bit different than what they've done in the past. So what they've done in the past is on that eligible telehealth services list, they had in the past put on there, this is where you can use audio only. Like they marked what service that you could use audio only for. They haven't done that this go around. So the implication is like, well, as long as it's a service that you could deliver, as long as the CPT code definition indicates you could use audio only, then you can go ahead and use it. And by that I mean there's nothing in that CPT code that would require some sort of like visual cue or that would need some sort of visualization of the patient in order for it to qualify. There's a lot of questions there about like, well, but there are codes, there are 9800 series CPT codes that are specific to telehealth and also specific to audio only. Right now, Medicare does not reimburse for any of those 9800 codes, any of those telehealth codes, except for one. They reimburse for 98016, which replaced G2012, brief 5 to 10 virtual check-in visit. And and that's not considered actually a telehealth code. That's underneath a different category that I'll talk about later called communications technology-based services. But right now, Medicare does not reimburse for any of the other 9800 codes. And that can get a little confusing for folks, I understand, because there are some Medicaid programs that do reimburse for those codes. However, Medicare does not. So despite the fact that they are specific telehealth codes, despite the fact that they have specific audio only codes in that 9800 series, they are not codes at this time that Medicare reimburses for. And the reason Medicare has said that they are not going to reimburse those codes, at least in the past, previously, what they have said is in statute, if you look at the telehealth section for Medicare and how CMS is supposed to treat telehealth, is that telehealth is a one-to-one replacement for an in-person service. So we gotta reimburse for those in-person codes. So that is why that's the reason they have given over the last couple of years of like that is why we Medicare CMS does not reimburse for the 9800 codes, except the one exception is 98016 because that replaced G2112, which was never telehealth code. It was a communications technology based service code. And as I said, I'll get to that a little bit later in the presentation to explain that. So FQHCs and RHCs. Again, this is where it gets a little bit tricky and a little bit more nuanced in their policies. So FQHCs and RHCs are actually divided up, have two different categories and how they can use technology to provide services and get reimbursed by Medicare. There is their regular service, just like their regular old way of providing services, and that is for mental health. That if they use telecommunications technology to provide mental health services, that's not considered telehealth for FQHCs and RHCs. That is just considered a plain old mental health service that an FQHC and RHC has been delivering, and they are able to like bill that way, like just the plain old service, and they will get paid their usual PPS and air rate. So that's permanent policy. Now, how did that come about? A couple of years ago, CMS changed the definition of what a mental behavioral health service meant for an FQHC. And they included in there, oh, they can deliver it via telecommunications technology. And that just changed the definition what that is. And so uh, FQHCs and RHCs can just use telecommunications technology, provide a mental health service, and they get paid their usual rate because it's just considered a plain old mental health visit for them. Now, they did put in there, and this goes back to that prior in-person visit, they did put in there that if you use this, there needed to be like a prior in-person visit. Again, that was waived. That was waived by HR 7128, the congressional bill. So that requirement was waived. But even if like the waivers all ended and like FQHCs were then required to do that prior in-person visit, again, they would still be able to provide mental health services via telecommunications technology and still get paid their usual rate. However, for medical services, that type of definition change did not happen for FQHCs and RHCs. CMS considered it. They did sort of say we want feedback from you guys in previous years, like in their physician fee schedules guide. They said we want feedback from the public on like should we expand the definition like we did for mental health and like add that services provided via telecommunications technology fits into the definition that they could do for medical services for FQHCs and RHCs, but they never actually went so far as to actually propose and institute that policy. So for medical services that an FQHC and RHC applies, that is still considered a telehealth service, and that comes underneath the waivers. So the waivers is telehealth service for medical services that FQHCs can provide. So and you're going to say, well, what's the difference? They're both using technology. Yes, they're both using technology. The difference is the terminology that they're using. For mental health services, CMS has defined that as telecommunications technology. For medical services, it's defined as services delivered via telecommunications systems. And actually, telecommunication systems is in federal statute, that phrase there. So that is how CMS has separated things out, is like the medical services are telehealth services being delivered by FQHCs and RCs, and they're being delivered via a telecommunication system. And so they have to follow the telehealth rules. However, mental health services can be delivered via telecommunications technology, and they can follow rules that we CMS have put in place for FQHCs and RCs, which means they can do this. They can get their usual rate, though we have some requirements on them as well too. So all that to say is like FQHCs and RCs kind of have like this split way of doing things, and billing is a little bit different too. Mental health services bill like their typical way they would bill mental health services. Medical services, because that's considered telehealth, they need to bill using G2025, and then they get a special calculator rate, which I think at this point is like about $110 or something like that. And this is also dependent on them being able to continue this on those federal waivers as well too. Now, wading into, I was talking about communications technology-based services via telehealth, et cetera, et cetera. So this is how CMS approaches things. They have two different buckets of policies. They have their telehealth policies for services, and then they have another bucket called communications technology-based services, CTBS. Telehealth policies are things embedded into federal statute. So these are like the permanent telehealth policies. This is where the waivers come into place. And as I mentioned earlier, the way they distinguish it is like those telehealth services are services that replace an in-person service. So if you were able to get that service in person, it and if you're able to get those services in person, if they're being delivered and if they can be delivered via telehealth, that they would cover them. And it's a certain list of CPT codes. It's also why they have said, as I said earlier, not adopted those 9800 telehealth codes, because they said, well, in law, it says it has to be these certain services, and those are in-person services. So we can't suddenly just replace everything by this new set of codes, because these codes aren't a replacement for in-person services. So that's like the CMS logic of why they haven't adopted the 9800 codes. And again, these services are what's ruled by those federal policies, those federal statutory policies, and what is like dependent on the waivers and like being more expansive. You have a second bucket called communications technology-based services. These are not embedded in federal law, so therefore they are not impacted by the telehealth waivers. These are controlled right now by CMS and how they want to administer these. And the difference that CMS has said is these are services that are not a one-to-one replacement for an in-person service. They are services that technology make possible now. And they didn't exist like in an in-person way. It's just something because technology has advanced to this point that we can deliver these services and we want to reimburse for them. And what are these services? This is where your remote patient monitoring services are. So it's like this whole sort of category of like your e-consult, your e-visit, your remote patient monitoring, your remote therapeutic monitoring, your virtual check-ins. This is where all these visits are come under these communications technology-based services. And they all have their different quirks and policies, but they are not dependent, or they are not ruled by what's in federal law, like telehealth policies. These are all just policies that CMS has set up. So they have set up things, a requirement of like, you need patient consent for some of these. That actually does not apply. There's no patient consent requirement on telehealth services. But for CTBS services, they do. They may require that they be patient initiated. They may also only be for established patients. So they have like their own sort of requirements there, but they don't have those telehealth requirements underneath permit policies, such as, oh, you need like to be in a geographic area, or oh, only these types of providers can do it. That doesn't apply to these. So this is like a little bit different. And I know some people got confused for this. So definitely over the pandemic, it started to people like kind of started lumping things together. It's like, no, especially if you're talking about Medicare, they keep them separate. So keep in mind, there's like this whole other group of technology delivered services that are not impacted by the telehealth waivers. Then one last thing on the federal level that I wanted to cover is controlled substances and prescribing. So just really quickly, this is where you can use telehealth to prescribe a controlled substance. Prescribing stuff, rule of thumb, controlled substances, it's federal law. Everything else, it is state law. But under federal law for controlled substances, they say if you're using telehealth and you have and that telehealth provider has not examined the patient in person beforehand, if you're using telehealth, you can only use telehealth then to prescribe the controlled substance if these in these situations, and it's if like that prior in-person visit had or prior in-person examination by the telehealth provider did not take place, these are the only situations in which you can use telehealth to prescribe. And they're usually like again very narrow. They're sort of essentially having the patient in either like a DEA licensed facility or with a DEA registered practitioner. Other exceptions are like if they're in an Indian health facility or a VA facility. And then one of the exceptions is if we are in a state of public health emergency. That was how this was like waived, like that prior in-person visit and not also fitting into one of the other narrow exceptions. That's how that was done, like during COVID, was because a public health emergency was declared. Congress never did anything. Congress didn't have to pass anything for prescribing controlled substance. It was already baked into federal law. It just got triggered by that public health emergency declaration. So when the public health emergency ended, again, it was a situation where the DEA was issuing extensions within their power. It wasn't something they had to wait for Congress to do. The DEA could decide to extend the waivers to continue to allow people to use telehealth and not have to fit into one of the exceptions or not have a prior in-person examination. And they've done that a couple of times since the end of the public health emergency. And they did it again last year and said, like their fourth extension, well, they're going to extend it until the end of 2026. So right now you have this policy that's like a little off track from all the things I was talking about with Medicare. Medicare for that for the most part, things are ending at the end of 2027 unless something else is done. But for prescribing controlled substances, that's ending in 2026 this year. Now, will DEA extend it? Who knows? I don't know. I will say that at least historically, they start giving indications of what they might be doing in early fall, like around that September timeline. But they kind of waited late to like actually formally say that they were going to do the extension. There were like signs and there was like paperwork filled, but for it to like get approved, at least last year for this last 1 year extension, that was like not until December. But they were giving out early indicators in September and October that they were likely to extend it an additional year. I don't know if they're going to do that again. Um, we're just gonna have to keep our eye on it. Their DEA DEA is like an agency where I've have yet to like really, kind of been able to uh figure out like a good contact over there to talk to you about this. So they're like a little bit harder nut to crack there. But right now, the prescribing controlled substance waiver is extended until the end of this year. So keep that in mind as well. And that is it. That is our CCHP website. We also have a newsletter, and then that's our contact information. And I think we have time for questions, Antonia.
Absolutely, we sure do. Thank you so much, May. You're always so thorough, clear, and relatable. I would like to open it to our attendees to see if they have any questions.
I think I could put my video back on.
Yes,
Yeah.
you're not lagging
Yeah.
anymore.
For whatever reason, lately it lags whenever I have a PowerPoint that I'm sharing. So
Any questions from our
it was a
attendees?
it was a lot. My apologies. I know it's a little bit of a fire hose. So
Or you did your job very well and answered every question that they had. We got a quiet group today. It was a lot of information. I really appreciate how you break it down and make it so clear. I learn something from you every time I attend one of your presentations.
oh,
So
well, thank you.
You're welcome.
And if you do have questions later that come up, do feel free to contact May directly or all the TRCs talk. So if you get any of us, you get all of us.
Yeah.
Absolutely. Well, we
UMTRC is very smart on this stuff as well too. So, highly encourage you to also contact them with questions.
absolutely. Well, Danielle, do you want to close us out with our oh, we've got one. Any activity to extend the waivers or make them permanent?
Hi, Cynthia. I know Cynthia. Um, so I actually had a conversation with like Senate staff like a few weeks ago where they had asked um talk to me about like, what would happen if we made things permanent. There's interest in talking to Senate staff. The one thing that they seem to have a roadblock, a block on or a concern about is the cost of like, oh, this is going to increase costs. I did my darndest. I pointed out to them that we've had like these flexibilities in place for like a long time. Like it hasn't really increased costs. So, and they even admitted, they said like, well, they estimate it's going to increase like, about like $1 billion. I said, $1 billion in like how big of a budget though? I mean, that's like a small amount. But that seems to be the biggest hurdle there and is like, the perceived that it's going to cost so much. It's like, is it really? Um, but I think what happens is it's just sort of like scope. They say they hear $1 billion increase and like, oh my God, that's a lot. And yes, it is a lot of money. In the scheme of things, though, when you talk about the entire federal budget or just even CMS's budget, is it a lot? I suggested to them, maybe you do percentage. It's like, oh, it'll only increase the Medicare budget by like, 0.001% or something like that. I said, maybe that's like a little bit more palatable to the audience. I don't know if that argument made it any weight with them there. I mean, they were like they were trying to figure out if I could figure out a budget neutral way for them to spin it. And I was just like, but it's not a lot and you'll help a lot of people. So, so that's where we are on that. So I don't know, Cynthia. I don't know, but that was my latest conversation with at least some staffers.
Any other questions? We might get 15 minutes of our life back, everybody.
Ooh,
I know. Hey, don't tell anyone you've got this 15 minutes on your calendar. They'll take it up. So,
I know.
um, please do let us know
Did you
how.
get hold on, did you get enough time for your CE credits though?
Yes, we're about to say that now.
Okay.
So we're
All
gonna
right.
go ahead and let everybody know. We have dropped it in the chat. Also in follow-up communication, please complete the post-test and the knowledge assessment from today's webinar, and you qualify for 1 hour of CEUs through the National Association of Social Workers. Here's our QR code for our feedback survey that is linked to our post-test. So if you do one, you'll get linked to the other one. And then join us next month for this is actually an innovative process we're trying here, a Simulive event where we're going to host telehealth boot camp from June 9th through the 23rd. And May, you actually participated in the telehealth boot camp series this year. So we are making that available to all our Ohio partners. So pretty exciting. Please register for that. That's also in the chat. And I think our disclaimer is next, which is just some light reading. Um, for everybody, and that closes us out. So, May, thank you so much for your time, and I will be in your inbox for the update come
All right.
2027. Thank you
Okay,
so much.
everyone. Have a great day. Thank you.
You too. Bye bye. Bye, everyone.